Dr. White, can you tell us what a medical home is?
A medical home is the concept of where you can go and when you have any type of medical condition or problem, where your providers, the staff, are involved with making sure you receive the total care or holistic care for your particular needs. I think that when we think about a medical home, we think also the fact that you're going to just get the, what I would say, medical care, but I would love to extend that to social, psychological, mental, as well as the physical care. And I love to add the caveat, even spiritual care, because people need spiritual mentoring as well. So to me, that's what a medical home should provide, total holistic care for a patient and their needs.
So how would a medical home benefit children and youth with special health care needs?
I would love to say that's a special interest that came out of pediatrics back in 1967. We actually coined the term, the medical home concept, way back then. In 1992, we broke it down into really established parameters which, the medical home would be, as we would say in pediatrics, applicable. And amazingly, it was for special needs children. That's where we spent the entire essence of our concept of medical home. I'm thankful today that it includes way more than just people with special care needs. It's talking about patients from all walks of life. And that, I'm thankful, has come out of the NCQA, National Center for Quality Assurance. It was evoked through a great article from the Institute of Medicine back in 2001, where we need to change our whole concept of how we provide medical care to patients. And I think it's a wonderful, wonderful, wonderful program when you look at it in its totality. But back to your question, special care needs. I think children with special care needs require many, many different aspects of medical care. They require more than one provider. They require assistance from all of their specialists that may be dealing with their particular entities and problems, as well as the paramedical fields that may be involved, social work, physical therapy, occupational therapy. You have many people involved with special care needs child. And as a result, if it's fragmented care, then the patients are just running from here to there and no one understands and sees them as a total person. And the concept of medical home is we want a special care needs family to realize they're loved and their needs will be met and they don't have to feel fragmented and seem as if no one really cares. And what we try to do there is there's one place that should be your general practitioner who makes sure that all these other entities are combined together to provide the care that's needed and coordinated for that particular patient and family. And by doing that, then the families can feel like, wow, someone really cares. And they're not out there by themselves trying to handle difficult circumstances and situations and trying to put it together themselves, coordinate it for themselves. The medical home says, listen, we are going to collaborate with you as a central focus, as a parent, as a patient, that you're the central focus. You know your needs. We want to make sure we meet them and coordinate all the care providers that are providing ancillary care to make sure that your condition is well managed and taken care of. That's the ideal of a medical home for a special needs person.
On the doctor side of medical home, what does that require of you as a physician?
That's a great question. I would love for our community to understand that being a patient in a medical home takes a lot of hard work and major change. Medicine has not been practiced this way, regretfully, in the United States over the past several years, and is not taught in medical school. We're hoping that this now become part of the agenda to teach doctors in medical school, and that is how to become more involved in the community, to change the concept of medical care. And it requires, therefore, a cultural change. We actually have to go through quite extensive training in trying to change the culture of the way our practices are set up. Pretty much it's been geared in America to just give you acute care. You walk in the door, we handle your problem, give you a prescription, you go home. And that's what's expected from a lot of patients. But patients in medical homes says, stop. That doesn't work well anymore. The patient needs to be a part of what your decision making is. They need to understand the responsibility they have. So we have to change our culture. We have to go through a lot of training to change our culture. So patients in a medical home doesn't mean just the doctors are changed and how we think, our entire staff, all the way from the people who answer the phones, to your receptionists coming in the room, to your nurses, to everyone that can actually be a part of this practice. We have to change the way we are. I kind of smile and say it's sort of like the Ritz-Carlton. When you go there, even the housekeeper says, well, hello, how are you doing, Mr. White? They all know who you are in what room, and they all respond to you as if you're part of the family. That's what we're trying to change in the concept. A patient comes in, they're part of a family. They're no longer just an entity or a number that just walks in the door. So from our standpoint of view, we have to understand what it means to have better access and continuity of care, giving them a provider, letting them make a choice of who they want to see, and try to make that choice available as often as possible. But when it's not there, still have the access, and if someone else is there, they have all the complete history that they can still respond to the patient and say, aha, I see you were in last time, or I see that you have seen Dr. So-and-so, and that's your physician. How may I help you today? What are your concerns? Changing that attitude. And then recognizing that we have different populations to manage in the communities, not just one population. There are many different ethnic choices, cultural choices that are out there. We have to understand our patient population. We got to make sure we learn who they are and how can we best meet their needs, and find resources tailor-made to them and make it seamless, not like they're being isolated, but that you're just normal. You're part of the family, even though you may have a different ethnic viewpoint. These things require changes in teaching to all your staff and all your members. We have to develop teams, meet every morning, talk over the patients that are coming in, identify what may be an anticipated problem and what may be an anticipated resource that we need to identify beforehand. So when the patient comes in, we can talk to them about it, even if they don't bring it up, to try to let them know. If we see social needs and see children that may be in the wintertime without socks on, we don't want to embarrass the mother, but we may ask, you know, is there any kind of resource we could refer you to? Here's an opportunity to take advantage of this, because we want that child to be warm and well dressed, and help them and understand that's a part of the child's health care. Social needs, on and on and on. We have to learn these things and change how we view. And we learn how to track and coordinate when we send them someplace, and where you go. Check with that referral person. Make sure the place that we refer to really made an appointment. Did the appointment go okay? These are things patients don't know we're doing on the backside, so that when they come in, we can make sure they made that appointment, they were seen, and have the outcomes of what occurred at that visit. So we have to stay on top of those things. And most importantly of all, as we do all that and track and coordinate the care, we have to also track and coordinate what we're doing and see, how can we get better? How can we improve? And I need our patients to know that's our attitude. So come in, tell us things, even if they may appear to be negative. That's the only way we can become better. And that's our desire, to become better. And we need our patients to know, you're part of this family too. Help us meet these criteria so that we can improve our care to you. That really then becomes true patient-centered medical care.
Dr. White, you have a resource book that you give out to families. What are some resources that you often refer them to?
I'm glad you put it that way, because every particular case has its own needs. And what we have done as an organization is we try to go to our community, talk individually to all the resources that we can find that can aid in helping any one of our patients with any need they may have, to find a place that can help them in the community. We believe very strongly in teaching patients how to care for themselves, self-support, and to get them community resources that can help them in ways that we could never do it as a medical practice. And so with the varied resources, I think our book is pretty large. So we have a lot of resources out there. I know that in the past we have used quite often Babies Can't Wait, and we recognize that there's a new great program that we've become aware of, and that's Parent to Parent of Georgia, which is an outstanding free program, especially for children of special care needs, that will actually meet with the parents and help them to be able to establish exactly what they need and help them in any way possible to make sure those resources are at their fingertips, and stand by to be a resource themselves as far as being able to handle some of the questions and concerns that may arise in their daily living.